So welcome to TCTAP wrap-up interview. And today's topic will be the Bifurcation PCI. And I'm BK Gu from Seoul National University. And my co-moderator is Dr. Mamas, Keele University, Oxford, UK. And we invited three experts in Bifurcation PCI, Professor Jung-Min from Asa Medical Center, Korea, and Adrian Benning, Oxford, UK, and Niels Holm, Aarhus University, Denmark. So we're going to review the whole sessions we've done today, and we'll talk a little bit more about the Bifurcation PCI. So, Dr. Mamas, shall we start?
Thank you. Yes, I mean, we often have these bifurcation sessions in very many meetings. I mean, Adrian, why are we so interested in PCI and bifurcation lesions?
I think it's to do with perhaps the fact that there are so many options, there are so many opinions, and we still don't really know. There's not one single answer. And I think that's probably the reason. And we've looked at dedicated stents, we've looked at different techniques. But the reality is, even if two bifurcations look quite similar angiographically, when you start to treat them, then things change. And you have to be reactive and you have to understand those changes in order to optimize your result.
So, Jung-Min, there was a very interesting talk at the bifurcation session that we were all at around how to assess significance in bifurcations, particularly in left mains. I mean, different trials use different cutoffs. I mean, how would you go about that when deciding to PCI?
Yeah, that is the big. What is the big problem in the clinical problem in nowadays? Because we don't have the exact assessment of left main, the significant left main disease. So we have two tools to evaluate the left main disease. First is IVUS, very traditional. There is minimal lumen area criteria. The Western country used 6 square millimeters. We published data 4.5 square millimeters. 4.5 square millimeters compared with the non-left main stenosis, the left main 4.5 square millimeter positive predictive value is very high to predict the positive FFR, around more than 80%. So if left main is the minimal lumen area, it's very small, definitely positive FFR. For another side is the functional assessment FFR. FFR, there is a lot of limitation to evaluate left main, but even though using the pressure wire pullback or considering the distal downstream disease, then you can evaluate it, not perfect, but you can apply the FFR concept in the left main disease assessment.
There's also a lot of discussion around, once you've decided that the left main needs intervention, whether we adopt a surgical or a percutaneous approach. I mean, I guess maybe I can start off with you. I mean, what do you take into account from your decision-making process?
So first of all, maybe it depends on the location of the lesion. So osteo simple shaft lesion, so we can treat it very nicely with the simple procedure. But the question is that this the left main. So in my daily practice, it depends on the downstream disease. If there's a multiple diffuse downstream disease, I'm saying that the left main is coming from down to top. So I generally send the patient to the surgery, but it's a kind of focal left main distal bifurcation lesion. So I do not hesitate to do a PCI because it's quite general. I can say general in this area.
Adrian, I mean, you were strongly part of the Excel trial. I mean, how do you think Excel has really changed our way in how we think about revascularization for left main?
I mean, Excel wasn't a perfect trial.
Yes.
But it took patients with low and mid-tertile syntax scores, which meant it was left main plus. And it showed, really for the first time in this group, the outcomes were similar with surgery versus PCI. And the key thing there is the safety for me.
Yeah.
And I think we've then combined those data with the data from Noble and Syntax. We've done patient-level meta-analysis, and that's really confirmed that safety signal. So I think where we were was when PCI kind of began, the left main was, no-go. Now I think there's very strong data to suggest that, particularly for isolated left main disease, that PCI is both safe and efficacious. particularly if you image and you have the tools that you need to treat that pattern of disease. There's often calcium. You need to have a range of techniques in order to do it properly, and you need to be able to make sure you do your best job in the cath lab. So I think Excel was a threshold which we've gone across. I think it reflects the evolution of stent safety. We're not dealing with first generation stents. The stents that we're now dealing with give us long-term, robust outcomes.
Niels, you're the PI of the October trial, and that's really changed perhaps how we think about using imaging in these sorts of lesions, particularly, say, left main lesions. How do you think we should adopt our imaging use in light of your trial?
Well, I think I just want to echo what has been said, that left main PCI is here to stay. We have the quite equal mortality, but we also still have some room for improvement. And we are lagging a bit behind on myocardial infarction, repeat revascularization, and we are facing a downgrade in the European guidelines for PCI in all complexities of left main lesions. So I think it's paramount important that we do our very best whenever we're dealing with left main. We should always do our best, but we are really held to our highest standards in the left main setting. So we have shown, other trials have shown that we can improve outcomes with routine use of intravascular imaging, and that's particularly true for the left main setting. And if we start to apply imaging in a systematic fashion, that we really, again, do it systematically, and we check all the stented segments and edges and so on. We check for the small accidents and catastrophes that are quite frequent in left main stenting. Well, then I believe we can get a better outcome that compares much more favorable to CABG, and then downstream maybe we could start to maybe compare again with the higher quality of PCI.
I guess in South Korea, you're using imaging in almost all of your left main. I mean, how do you use that information from imaging in terms of your lesion preparation, your sizing, how you approach the case?
Yeah, so that as you know, Korea, Japan, especially left main PCI, most are guided by intravascular imaging. And as of now, IVUS is dominant, and with the increased use in the OCT. And having said that, so I personally think that the pre-lesion evaluation for both LAD and circumflex is very important to decide whether atherectomy is needed or whether the other strategy is needed. And because I love physiology, but physiology doesn't tell you which strategy is best, which two stenting technique is best, and the selection of the stenting strategy is dependent, especially which lesion should be dilated first, etc. So that the intravascular imaging assessment for both main and LAD and circumflex, and then decide the treatment strategy. And my preference is doing intravascular imaging at each step of my procedure, and then finalize the procedure with the adequate, minimal stent area information, and finish the procedure. So I personally think that having final nice and high MSA is far more important than complicated steps we have to memorize during the bifurcation PCI. So that I personally think that that's why we need intravascular imaging, unless, as October trial show that lots of mechanical complication happens, and unless it is fixed, the patient outcome will be worse. So that's how we use intravascular imaging in complex and most left main bifurcation PCI.
I mean, there's a lot of discussion, Jung-Min, in terms of single versus two stents approach. We've got EBC main versus DK Crush 5 trial. What's your approach in trying to decide whether you use one versus two stent approaches?
Yeah, a very good question. I didn't focus on the one strategy. I mixed the two strategies, two stenting or one simple course of stenting. As Dr. Gu mentioned that when I decided two stent strategy, when I see the circumflex ostium looks very tight, I decided systematically to stent strategy first. Which is stent strategy? I prefer the crush technique. because it's the most familiar technique for me.
Okay.
I think everybody have to have one best bifurcation technique for their own procedure, I think.
So Adrian, I mean, I guess, from the European perspective, we're more likely to use provisional. I mean, are there any cases that you would start up front with a two-stent approach?
Well, I think there are, and I think the difference may reflect differences in the patterns of disease that we see. The definition 2 criteria of that long side branch, 9 millimeters plus, I don't see that much of that in the UK. And therefore, the provisional approach suits me well, and my go-to two-stent approach tends to be the clot. But I think, as Jung-Min says, we have to have an approach that we prefer, and I think there are advantages and disadvantages to each. But I think the provisional, when is not, if it circumflex, it's long and diffuse and severe, but there's no real point trying to do a provisional approach.
So I have one concern that
Yes.
nowadays provisional strategies are too overemphasized. That's all. The result in the many operators cannot do the two-stent technique. Don't have enough experience for the two-stent technique. For example, if operator fail to the simple crossover jail the circumflex, only the operators can do two-stent technique can overcome this situation. So simple crossover stenting is not that simple sometimes. So we need more experience to do the simple crossover stenting.
It's an important mantra of the European Bifurcation Club is it's not just one stent. It is a layered approach. In order to produce the layers, meaning in order to get to where you want to be, as you say, you have to have the skills in order to make sure that the result is optimal. If you haven't got that, then you shouldn't be in the left main.
I agree.
I mean, we often talk about sort of, angiographic criteria. Of course, definition 2 angiographic criteria. Niels, maybe I could ask you, I mean, are there any sort of imaging criteria that you, or maybe not even criteria, any sort of imaging that you've seen that would make you move more towards an upfront two-stent approach?
Well, it doesn't differ that much from the angiographic criteria. It's just we just get the information with intravascular imaging. We know that the C-arm cannot go into a sufficiently caudal position in 40% of the cases when you do left main to evaluate the circ ostium. So we really need the information to make informed decisions. But it's still about long side branch lesions, long severe side branch lesions. They are for two-stent techniques. We could see also in the October trial that the short lesions caused very little problems. As soon as we were beyond the 10 millimeters, then we had a lot of problems. And it's also we saw an additional effect of adding imaging in that game. So I think that it's important that we, from the beginning, to decide our strategy, use imaging, make the decision up front that, okay, this is left main, it's a high-stake game, so we need to do this, and we are ill-informed by the angiogram.
I think just planning is quite important, isn't it?
Yeah.
And I think when you see people getting into trouble, it's when they've started with a provisional technique in a case which an experienced operator would say, this is never a provisional case. There's calcium, the circumflex looks terrible. Why would you try to do that with a single stent? And then once they put the single stent in, then you have one hand slightly behind your back. You can't prepare the ostium of the circumflex as you would have done normally, readily. You might have problems wiring, you can have problems getting the balloons in, and you're then probably going to end up with a suboptimal result. And I think it's fair to say that for most people still, a selective, optimal, elective two-stent is always better than a bailout. I mean, that's just kind of tends to be the way.
I mean, we often talk about, stents as though they're a homogeneous thing, but they're not, of course. I mean, stents differ in terms of expansion profile, side branch access, longitudinal compressibility. I mean, what factors do you choose in terms of, choosing your stents for left main?
So in general, I don't care that much with the current second generation stent. So previously, I tried to memorize all the side branch strut opening, maximum opening, etc., and thickness, etc., etc. But I don't care that much. But short thickness, sometimes I do care because if I feel that the recoil happening, with the high probability, try to implant the thick stent. But the current generation stent, in general, it's fine. And also that kind of the coil type or the other type work. But I don't think it really matters with all these current generation stents because they are all working very well. And Jung-Min already mentioned during his talk that the DK crush was developed during the first generation stent. And now we have a very nice profile second generation stent so that we may omit those complicated procedures. So we've been discussing these issues with the kind of beginner. There are lots of, points where something happens during the very complicated DK crush procedures and also the culotte procedures, so that unless the operators understand the kind of strengths and weaknesses of each procedures, so that the simple procedure can be ended up with the very complicated and miserable scenarios.
I mean, we've talked about stents, but of course there's also DCBs. And when I mentioned DCBs during the panel discussion, there was a look of horror in the audience. What do you feel that there's any role for DCB? Maybe I can start with you, Jung-Min, in bifurcations.
Definitely instant restenosis lesion, I favor the 100% DCB. I don't like the overlapped metal jacket. But the small vessel, okay, I good. But my concern is for small vessel, before DCB era, I don't touch the small vessel. But nowadays, my mind try to touch them using the DCB. Particularly for large vessel, big plaque burden, a young patient, big plaque burden, and left main bifurcation, I still have a concern to DCB. Not DCB actually. DCB is just the DCB and balloon angioplasty same. Actually same. DCB is a balloon angioplasty plus drug eluting. So a good complication. How to manage the complication is the success. The main part of a successful DCB treatment. But based on the very early days left main PCI data, for left main, the balloon angioplasty increased the mortality very high. So
maybe I can ask the same question to Adrian. I mean, do you see any role for DCBs in left main? I mean, what's your practice?
I think less so in the left main because of the high recoil, the calcium, the importance of the side branches. As Jung-Min said, the drug coating is going to be effective in weeks and months. It doesn't keep the vessel open in hours and days. Yeah. And if you've got dissection, you're better off with the stent. And so we know that optimal expansion or optimal dilatation of the lesion is terribly important. My worry slightly is that we end up putting slightly too small balloons in because we're a bit worried. Yeah. We just hope it'll be fine. Yes. Well, that's not going to work in the ostium of the circumflex. That we know that. We know that message. I think there may be a role for DCBs, particularly in small vessels or bifurcations with relatively small side branches. But many of those small side branches don't need treatment at all anyway. Yeah. So I am enthusiastic about DCBs. I think there will be a role beyond in-stent restenosis, but I don't think we should run before we've walked.
A very brief answer then. In terms of, we've talked about techniques, we've talked about imaging, antiplatelet therapy. What is your regime? I mean, should we treat left main PCI differently from non-left main PCI in relation to antiplatelet therapy? What guides your decision making about type and duration?
Yeah, so that we may separate the two stenting versus one stenting and final MSA. So that if I'm very confident with the final MSA, even with the two stenting, I'm quite so, but not 6 months, but at least to try to one year. Okay. But the simple crossover may be different, so simply follow the general non-left main bifurcation PCI as well.
Anybody else have different approaches? What was yours?
Look at the syntax trial.
Okay.
The hazard ratio of stent thrombosis and left main is left main is a lower risk of stent thrombosis compared with the non-left main epicardial coronary artery stenosis. So for me, I don't change my antiplatelet therapy because of left main PCI.
Niels, you sort of shook your head slightly. Yeah.
But I think the debut symptom will often be death, if you have stent thrombosis in the left main. And with the very low rates of autopsy, we really don't know the true incidence of stent thrombosis in the left main setting.
So
I fully agree with a tailored approach where if you have a really good result, optimal result, you follow the regular guidelines. If it's less optimal, surgical turndowns and so on, where you really need to do, it might be longer, more aggressive.
So with that, I'd like to hand over to my co-chair to wrap up the interviews.
Okay, so that it really was a great wrapping up of not only the TCTAP bifurcation session, but the whole bifurcation issues happening in this world. I really thank my co-moderator, Dr. Mamas, and 3 experts in bifurcation PCI. And thanks for the invitation to TCTAP. And we close this session. Thank you very much.
Thank you.